Hello, everyone. Welcome to the Art of Fertility, a new podcast by ART Fertility Clinics. I'm Mona Garbi. Fertility is deeply personal, yet it often gets discussed in very clinical terms. This podcast wants to bridge the gap. In this series, we will be unpacking the science, the emotions, and the decisions that shape the fertility journeys. And for our very first episode, it felt only right to start with the medical leadership behind ART Fertility Clinics. Today, I have the honor to talk to Professor Human Fatemi, the Group Medical Director of ART. Welcome, Professor.
Thank you very much. Thank you for having me.
In my experience as a former infertility patient, turned into fertility patient advocate and fertility coach, I have sadly noticed that people lack any sort of reproductive education worldwide, not just in the UAE. We tend to take fertility for granted. We think it's going to last forever. Social media doesn't help between inaccurate medical information and misleading success stories that present only half of the truth. So I would like to start with the question, when should we begin to think about our fertility? When should we start planning for it? When should we get worried about it?
So first of all, thank you for bringing up this very important question, because you're absolutely right. You know what people do today? They read in the newspapers that this actress at the age of 48 or 45 got pregnant of a twin, and mostly they say it's a natural conception. And you, if you have not the deep biological knowledge, you will believe, okay, that's easy. So I'm going to the gym, I'm eating healthy, I don't smoke, I don't drink, but that's okay. What we need to know is you are born with a certain number of eggs. And this number of eggs differs among women. So with some women, the number of eggs decline much faster than others. And we know that this decline is not only a quantitative decline, but it's also a qualitative decline. It means even at a young age, if you have a reduced number of eggs, you are creating more genetically abnormal embryos. And something which is very interesting, and I'm going to ask you this question. I mean, you went by yourself, you mentioned through a treatment. Do you know, except human beings, which other animal goes to menopause? Did you ever think about that question?
No, I'm expecting a mammal, but I don't know which.
It's a whale. So the whale is the only other animal except human being which is going to menopause. Because even if you look back 500 years or 1,000 years ago, our life expectancy was much less. So the menopause and all what problems that we face with that did not exist at that time. So today we see a changing society. We are becoming older, but also the aging of the ovaries is accelerated. And this is something that many people don't realize. Just to give you numbers, at the age of 35, even if you have a good number of eggs, half of your eggs are genetically unhealthy. 50% of your eggs at the age of 35 are not healthy. If you are 40, let's say you go to the gym, you are healthy and you have a healthy lifestyle, you would say, okay, I want to get pregnant now. At the age of 40, 80% of your eggs are genetically unhealthy. At the age of 43, it's more than 95%. I think these are numbers that you should keep in mind. On the other side, imagine you are a lady and you have an accelerated aging of the ovaries. It means you have lower number of eggs. Let's say you are 28, 29, but your ovarian reserve is going down faster. The prevalence of abnormality also increases faster. So some women, even when they're 45, they have a good ovarian reserve, they have a decent chance of getting pregnant if you have a good number of eggs. But even if you are young and you have a depleted number of eggs, your chance of getting pregnant also declines.
But how would I know if I'm young that I have a depleted ovarian reserve? When should I start thinking about getting tested?
You see, that's a very difficult question to answer. The thing is, you know, once you reach a very low number, your cycle pattern starts to change. But that's already too late, because the moment you start having shorter cycles, normally the first sign of depleted ovarian reserve is that your cycles are not 28 days. Maybe they become 25 or 24 or 26 days. The problem is once you are there, it's already too late. I don't want to say too late, but you are already at the later stage of depleted. But if you want to know it, there are very easy tests to evaluate this. You know, today, if you do a scan, with a scan, there is a test, it's called antral follicle count. It takes 1 minute. Within 1 minute, a gynecologist can tell you if you have a good or bad ovarian reserve. If you don't want to do a scan, there is a blood test. It's called anti-Mullerian hormone. You do a test, and if your anti-Mullerian hormone is okay, it's okay. But if it is down, then you know that you have to take action. So if you want to go towards testing symptoms, you might be too late. So testing it and anticipating that there might be a problem is always better. So prevention is always better than once you have the problem.
What about egg freezing? When is the optimal age to think about it?
You know, if you take the numbers I just mentioned, you see below 35, 70, 80% of the eggs are healthy. But above 35, every year more and more eggs are unhealthy. So preferably you should freeze your eggs at a young age. Young age means less than 35, 36. And the other question would be, okay, if I freeze my eggs, what is my chance of having a baby with those eggs? Also, that is linked to the ovarian reserve. So statistically, you know, you need to have a minimum number of eggs at any given age you never have a guarantee, but to have a high chance of a live birth. So if you ask me what is the best age, I would say less than 35. Now, does it mean that after 35 you should not freeze your eggs? Of course, you can, but be realistic. The prevalence of abnormality is significantly higher.
You mentioned fertility being influenced by lifestyle. And that women who go to the gym and people in general, because also men, right? They might feel that their fertility might last longer because they are healthy and they are fit. This is one of the most common question, I would say, that comes up on infertility groups. How can I improve my fertility? So I would like to change the question a bit and ask you, is there anything that people can do in order to stop the decline of their fertility? Like, does lifestyle impact fertility? Can we put a stop to the decline?
Again, another important question. Unfortunately, you know, there is a lot of financial interest also involved in fertility treatment. So many people come up with many stuff to sell in order to make money, but it's not evidence-based medicine. So if you ask me today what is there to really help, I would say, I don't know. I mean, there are not many stuff out there that would say, okay, it's going to improve your fertility. In the past, you know, we thought if you administer some drugs, it would increase the number of eggs and so on. But there is one thing specifically in the GCC countries that we have identified, which is one of the primary causes of an accelerated aging of the ovaries. Really something which is extraordinary. So in Europe, when you see women, normally when they get older, they have less number of eggs. So we saw here immediately, and every time we have a clinician from Europe moving to here, we have to teach them to unlearn and relearn because they don't understand what they see here. So here we see a high prevalence of women with low number of eggs, extremely low number of eggs at a young age, 25, 30, 32, 35. So we started looking, why is that? Why do we see so many women? We define them as poor responders, low number of eggs. We published a paper a few years ago. We see about 60 to 70% of all women that we see are poor responders. This is a lot. This is a lot. So we started asking ourselves, why is this happening? So you said lifestyle. Do you think what was number one which came out? Lifestyle, but what in lifestyle? What do you think, what is different between here and Europe, for example?
I don't know, sedentarism?
Sun exposure.
Sun exposure.
You see, they have the abaya and they cover completely. They have a lack of sun exposure and even some cover their faces. So we published a study 1.5 years ago. We stratified according to how much they cover. The more they cover, the lower the vitamin D, the lower the ovarian reserve. So lifestyle, of course, too much sun is unhealthy. But imagine you have a plant and you put this plant in the dark. The plant will die. You can give as much water and fertilizer as you want. If there is no sun exposure, the body is the same. You need UVB light. If you do not have UVB light, at some point, your body will start having symptoms. And we see that one of the symptoms is an accelerated decline of a number of eggs. We publish many papers on this topic, but also you create more genetically abnormal eggs if you have vitamin D deficiency. You might say, simple, I take a pill and I solve the problem. No, because the pill that you take is not the same what sun is creating in the blood. Because sun initiates a cascade of reactions and the vitamin D is just one part of it. There are many, many other actions that is not being covered with that. So lifestyle, I think you need a little bit of UVB light. UVB light is 9:30 in the morning. How much? 20% of the surface of the body needs to be exposed. How long? 20 minutes. But it depends on your skin color. So if you have a Caucasian skin color, 20-25 minutes. But imagine you have an African skin color, completely black, you might need up to 2 hours to have the same amount of vitamin D absorption as someone with a white skin. And anything else would be between 20 minutes and 2 hours UVB exposure. I think this is one thing. Body mass index, doing sports, having a healthy food, of course, all that plays a role. But one thing we see here, which is extremely important, is lack of sun exposure.
Would you say that the UAE and in general this region, the Gulf countries, that they have higher rates of infertility compared to the rest of the world?
Absolutely. Without any doubt. Absolutely. What we see here is something we have never seen in any part of the world. So we all have worked in different parts of the world. But what we see, and we also travel quite a lot for lecturing around the world, but what we see here is by far ahead of any other country. And there are variable reasons why we have that. One is, as we just elaborated, the declining of a number of eggs because of lifestyle. And the other thing that we see, when you marry your cousin and you have a high prevalence of, we call it consanguinity, marriage in a family, first or second degree, we know that you create more genetically abnormal kids. That we know. But we didn't look to genetic abnormalities. We looked to the fertility of the offsprings. So we looked what happened to the daughters and the daughters of the daughters. And it was very interesting to see that the daughters of parents who are cousins, they have a rapid decline of a number of eggs. So they go very early to menopause, they have difficulties to conceive. And it also depends how many generations you marry. You see, it takes you 4 to 5 generations, your bloodline will stop completely. So the second reason is marriage in a family. The third reason is, the prevalence of C-section is very high in the region. If you do a cesarean, you reduce the receptivity of a uterus for a subsequent pregnancy. And that's something many doctors don't know. So every C-section reduces the receptivity of the uterus. And the prevalence of C-section here, according to the DOH data, it's 40%, but from what we see, it's 60%. It's much higher. Do you know what is the recommendation from WHO? 15%, 1.5.
What happens then?
What happens is that you have a higher prevalence of C-sections. The C-section, you see, the uterus has different layers. One layer is called endometrium, which is responsible for the implantation. One layer is myometrium, is basically a muscle which becomes big and contracts the baby out. With a C-section, you cut and basically you create an opening between endometrium and myometrium. And these cells migrate. And the other problem is the way the closure is done is not always correctly. So basically you damage the uterus. So we know that every C-section that you do reduces the receptivity of the uterus. So that's another problem. So you have vitamin D deficiency, you have consanguine unions, you have high rate of C-sections. Last but not least, obesity, female obesity. According to the WHO data, UAE is with Kuwait and Saudi Arabia on the top countries with obesity. I think 60% of women in fertile age have a BMI which is considered overweight. And fat produces estrogen. There is an enzyme called aromatase. You see, if a man is very fat, he has breasts like women. Why? Because fat produces estrogen. This estrogen makes breast tissue. So women who are overweight, they have high levels of estrogen. That reduces also the receptivity of the uterus and increases the rates of miscarriage and also reduces the pregnancy rates. So you have already added many, many variables. Add them together, then you will see that the prevalence of infertility is really higher than any other part of the world.
Based on this, what do you think? How long should people try at home before seeking medical help?
I think it depends on the information you have. So if I answer your question academically, I would say if you're less than 36, 1 year. If you're more than 36, 6 months. But imagine that you have a significantly reduced ovarian reserve. If you have done this test and you know that the ovarian reserve is very low, even if you're less than 36, I would not waste time 1 year or 2 years. I would even go earlier to a specialist. So to answer a question simply, I would say less than 36, 6 months, more than 36, less than 36, 1 year, and more than 36, 6 months. But if you know that there is a problem, I would seek advice earlier.
What do you think could change the data for the UAE. How could we improve the numbers? Should we start by educating our children, our daughter? I know you have 2 daughters. I have one. We had the egg freezing conversation. So what is your opinion on this?
I think first we need to educate the educators. You see, we need to have a correct diagnosis with the educators, with the physicians, with the gynecologists, even with the IVF specialists. Because what we are discussing here, I mean, it has been published, but there is still a lack of knowledge. I think also the educators need to update the knowledge. And a mistake that we did, and still we do, we all study somewhere in the West. Okay, we come here, and we're going to replicate what we have learned there here. I always use the example, it's like you have a BMW and you go to a Toyota garage. I mean, it's a completely different mindset. And that is a mistake that we have done in the past. I think in the era of individualized medicine, initially you need to understand the cause, the etiology of the problem. If you do not understand the cause, it's going to be difficult to fix it. So this is why first the understanding and then informing the patients. Now, fortunately, the Department of Health Abu Dhabi under the leadership now, they are really proactive. They understood the problem and they are pushing the research, they are pushing in order to educate also the educators and to inform also the patients about this. But action has to be taken because really the prevalence of infertility is much higher than we see in the West.
And in the end, if a couple decides to go to a fertility clinic, among all the noise caused by the marketing, by the social media, how does a patient choose a clinic? Should they go to the clinic closest to home, to the one that has the highest success rates, and that's another conversation with the success rates, to the one that has the most beautiful Instagram account? How do we choose a clinic? Based on what?
I mean, again, another important question. You see, like you say, you can make a lot of noise. I'm the best, I do this, I do that. On the other side, making the noise and effectively being good in what you do are 2 pairs of shoes. What you as a patient need to know is that we IVF doctors, and it's going to be funny what I'm going to tell you, but that's the truth, we have no clue what we are doing. And that's the truth. Do you know how many years we exist? It's 45 years approximately. If you go to a cardiologist, you go to an ophthalmologist, you go to any physician, do you know how many years they have existed? Hundreds, if not thousands of years. We are only 45 years old. Do you think in 45 years we know what we are doing? By far, no. If you put back an embryo, it doesn't implant, you ask your physicians why not. Do you think they have an answer on that? No. Mostly we don't know. Why? Because the lack of research. So if as a patient you want to identify a good clinic, you need to look to the academic background of these people. You need to look, are they actively contributing to research? Are they globally well known? Do they travel around the world to teach others how to do IVF? What is the specialty? Some people might be good on ovarian stimulation. Some people might be good with endometriosis. Some people might be good with male infertility. So look at the history of their publications. Look how much they have contributed to developing science. Because once you develop science, you will be able to understand it better. Then you can individualize the treatment according to the patient's requirement. And then the noise is there, but you can filter the noise. And through the media today, if you go to scientific sites, put the name of the physician who is treating you. How much did he publish? What is his knowledge? Is he globally well known or not? I think this is how you can filter which clinic you go. And of course, the laboratory is extremely important. You need to have a holistic approach, a synergy between the lab, between the clinical physicians. You see, it's a lot of factors which do play a role. It's not only one factor that you have to look at.
When you meet a patient for the first time, what questions do you want them to ask you?
First of all, it is important because we don't put it in a beautiful package and give it to the patients. We are very transparent. We tell them the facts that they are because we don't want to sell hope. Because you say, okay, no, everything is good, it's going to work out. What is important that the patients ask is, can you tell me what is my problem? This is the question number one. If the patients come, and we used to say 20 years ago, let's say 40% is female infertility, 40% is male infertility, and 20% is idiopathic infertility. It means we have no clue what's the cause. If you ask me today what is the reality, I would say is maybe 80% female infertility 19% is male infertility, and maybe 1% is idiopathic. So idiopathic doesn't exist anymore. So ask, what is my problem? What is my diagnosis? And what is my chance of success? So don't start a treatment just saying, okay, we're going to see, we don't know what's the problem, but we're going to see what's the problem. No. Ask, what is my problem and how do you want to solve it? I think that's an important question.
You said earlier that infertility doctors, they don't know what they're doing. Well, definitely infertility doctors at ART know what they're doing because your success rates are high.
Yes, the success rates are high, but we also have failures. So you have to admit that we have very good results. We are very proud of that. But yesterday we had a meeting with the Department of Health and Innovation Department. We want to go to a place where when we put back an embryo, we have 100% pregnancy. We are not there yet. So we also have failures. Yes, we have over 70% pregnancy rates, but there are women, they create constantly abnormal embryos, and we cannot put back those embryos. The question is there any possibility in future to fix and preventing creating these abnormal eggs? So there is a lot of room for research, and hopefully in future we can also contribute to that.
If you were to think off the top of your mind at one of your successful stories, what would be the one that makes ART Fertility stands out from the crowd? What would be that success?
We have had this question a few months ago from the Department of Health, Ministry of Health in Abu Dhabi, and it's not one, there are two cases actually. There are two cases. One of them, both of them Emirati ladies. One of them was mid-40s actually. She did over 20 years of treatment in Korea, in Taiwan, in Belgium, in Spain, in the US, in the UK. More than 20, 30 cycles, and she never got pregnant. And we saw her when she was, I think, 42 or 43. I don't remember exactly. So already too late to treat. And we identified the cause of the problem, because the cause of a problem was there, but it was not identified. She had married her cousin, and there was a single gene disorder. And over time, the uterus became less receptive. So we found a problem. You cannot fix it, but you can identify the correct embryo and synchronize that embryo with the uterus. Unfortunately, she delivered, and she has a healthy baby. And another case was a woman where she was advised to remove her uterus because the uterus was really, the uterus was up to her lungs. And every time she was bleeding, she was almost in intensive care unit because of the pain. There is a disease called adenomyosis. And everyone was telling her, you have to remove the uterus. So we found a treatment for her where it took a long time. But at the end, without any surgical procedures, we made the uterus in a normal size. She got pregnant and she delivered a healthy boy. So these are cases where I would say it's almost impossible, but it worked.
Well, that's the beauty of assisted reproduction, isn't it?
Absolutely.
The impossible made possible. Thank you, Dr. Fatemi, for such an honest conversation. After all, what I hope the viewers take away after this is that fertility is more than just medical protocols. It's also about tailored approach, about educated decisions, and the right medical guidance in the end that the healthcare providers offer. That was the first episode of The Art of Fertility by ART Fertility Clinics. In the coming episodes, we will continue the conversations with clinicians, embryologists, and experts across fertility care. If you have watched us and you're feeling overwhelmed and uncertain, know that you're not alone. Stay tuned. We'll be back.